Our next speaker is Dr. Lisa Diller. She is the vice chair in the Department of Pediatric Oncology at Dana-Farber Cancer Institute and director of the Life Clinic for Childhood Cancer Survivors. She is an attending physician in the Division of Hematology Oncology at Boston Children's Hospital and professor of pediatrics at Harvard Medical School. Her interests include cancer predisposition, global health, and late effects of pediatric cancer. The focus of her research is the treatment of patients with solid tumors and the study of survivors, including the treatment of minimal residual disease and breast cancer in women as part of their late effects. Our next speaker, Dr. Lisa Diller.
Thank you so much. It's a pleasure to be here. I thought I'd like to keep this pretty casual, so feel free to interrupt and say, wait a second, I didn't understand, or I have a question, because you guys have seen a lot of slides and been talked at, and I'm happy to redirect. I don't have to go through all my slides. I just want you to enjoy this particular part, which is survivorship. So I'll start out with a little about me and about one of my patients. I became a pediatric oncologist. I started training in 1988. And at the time, I distinctly remember there was one child who had what we call high-risk neuroblastoma now. We didn't call it that then. We called it stage 4, who is a long-term survivor. And when he would come to clinic, my attendings would say, everybody come see him because you're never going to see this again. That's when I started my career. On the flip side, nearing the end of my career, my colleagues and I just completed a cohort study of almost 400 survivors of high-risk neuroblastoma. So we've come a long way. Yeah, and I'm pleased. It's nice to have a career that has that arc, if you will. It's terrible that that's the way it was back then. I got interested, even before I got interested in neuroblastoma, I was interested in survivorship because these kids would come to clinic. The doctor who started the pediatric oncology program at the Dana-Farber, his name was Sidney Farber. He was actually a pathologist. And he trained the first generation of pediatric oncologists, which is before my time. And they didn't really know if anybody would be cured. He invented the first chemotherapy, one of the first people to invent a drug called methotrexate, which worked in leukemia. So he told the patients, no one's really going to have any information about what happened to you as you get older and grow up. So you should get all your care at what became the Dana-Farber. It was called the Children's Cancer Research Foundation, I think, at the time. So I come on board in 1988 as a fellow, having trained in pediatric oncology. And our job as fellows back then, those of you who have kids or have been treated for neuroblastoma understand the concept of an attending, right? There was no such thing. You were the fellow, you took care of the patients. Yeah, there were attendings, but they were in their labs. So we would go to clinic, and the nurse would bring in paper charts, 4 volumes of paper charts, and say, John is here. Who's John? Oh, John had Hodgkin's disease 30 years ago. He's 35 years old now. You need to see him. And I would read through this chart and see the life that John had led. Now, John wouldn't have been cured in an earlier era, but now Hodgkin's disease was curable. But the first cures for Hodgkin's disease left him with a lot of what we call late effects. So he had had his spleen removed. That was one of the treatments for Hodgkin's disease back then. He had had radiation therapy from his chin to his pelvis. He had had chemotherapy. So he had no sperm. He was hypothyroid from the radiation to his neck. He was at risk for infections and had multiple bouts of infection because he had no spleen. There was one other thing I said. He was at risk for secondary tumors. So I remember seeing John and say, there has to be a better way than some first-year fellow thinking about this kid. And there has to be somebody thinking about how we learn about these survivors and take care of these survivors. And I found out that there was a national group forming called the Childhood Cancer Survivor Study. I don't know if there's anybody here who's aware of that study. So the Childhood Cancer Survivor Study is now has 35,000 young children and young adults enrolled in the study. It's run out of St. Jude's, but there are about 30 centers around the country that participate, including my center, and we enroll patients, and then they share their experience. Their charts are abstracted, what they got, what happened to them, whether they ever relapsed, whether they developed some other disease. And then they get a questionnaire every couple of years to find out what happened to them. And so much of what we've learned about survivors overall, not just neuroblastoma, is from the Childhood Cancer Survivor Study. So from looking at a patient, seeing some patients doing something kind of the old-fashioned way, it brought me to a career that's been like unbelievably rewarding. So, a little about one of my patients. That was me. One of my patients. So how did I get into neuroblastoma? So, there was a woman named Sue Kreisman who was a fellow with me, and she took over neuroblastoma when she became an attending. And then she got married and moved to North Carolina. So, one day my attending walks in and says, Lisa, you do neuroblastoma. So I said, okay, I wanted a job. I wanted to stay in Boston. I'll take care of neuroblastoma. So I read as much as I could about neuroblastoma. And at the time at the Dana-Farber, this was when the era, I don't know if any of you know this, but there was an era in which people thought that women with breast cancer should get stem cell transplants. And because they knew that they could support them through stem cell transplants with peripheral blood stem cells, and that way they would be able to give them more chemotherapy. So there was this sort of early 90s experience of giving women with metastatic breast cancer stem cell transplants. Turned out in a randomized trial it didn't work and it went away, but because I have the privilege of working in a cancer center that treats adults, and my boss said I should do neuroblastoma, and I knew we were working with a chemosensitive tumor, by the early 90s, the CCG, one of the cooperative groups, was studying transplant. I said, maybe we could do peripheral blood stem cells in kids and do 2 of them, because if one is working, maybe 2 works better. So we figured out that, yes, we could harvest stem cells in kids. So that was the first experience ever in little tiny babies to harvest stem cells. And then we wrote a protocol to do double transplant in the early 90s in Boston. And we did that in collaboration with CHOP and Emory and Utah. And we did it for a number of years. So anyway, we have this protocol open, and my patient comes in, and she's 3 years old, and she's diagnosed with metastatic neuroblastoma, and she was treated on this protocol. The name of the protocol, if you ever hear people talking about it, was called 34-DAT. And the drugs were, sort of the standard drugs that we still use during the induction period of high-risk neuroblastoma. And she had an abdominal mass, and it was resected, and she got radiation, and then she got double transplant. And when she was 6, it became clear that she wasn't making enough thyroid hormone, because one of her transplants involved total body radiation, which does in your thyroid gland. That's a pretty easy fix. You just take a pill every day. But then she wasn't growing, and then she didn't go through puberty, so she needed to and that was because of the radiation to the ovaries and perhaps the exposure to some of the drugs that she got during transplant or during induction. So she was started on estrogen and progesterone, and then she graduated from high school. And she went on a trip. Oops, I didn't mean to do that. She went on a trip after graduating from high school with 3 of her buddies. And there she is in London on a bridge right near St. Paul's. And I show this picture to think about what would her life be like. She has short stature, there's no doubt. She's at her full adult height. She's about 4'8". What's her life going to be like? And when I said to her mother, how does this feel? She said, she's great. I'm happy she's alive. You did what you needed to do. It'll be okay. And here, I got this a few months ago. This is her 30th birthday. So, this is, again, kind of the full circle of where my career has gone through the eyes of, sort of through the lens of a single patient. Now, of course, I've lost patients. It hasn't always worked. Some of the late effects are unbearable. I don't mean to minimize or paint a too rosy picture, but I do want you to know that this is a remarkable change that I've seen over the course of my career in the outcome of high risk neuroblastoma and the therapies we have available. What, how did that happen? I think you heard from Ro Bagatelle today, and maybe you heard from others, that it's really been kind of multifactorial that we've been able to improve outcome for high risk neuroblastoma. We've done multiple clinical trials supported by the NIH and usually in COG of transplant, of double transplant, of retinoic acid or isotretinoin, cis-RA, of antibody therapy. Plus, surgery's gotten better, radiation's gotten better, our imaging has gotten better. We can provide better supportive care. We probably have better information about who really needs what therapy based upon the genomics of the tumor. So all of this kind of gets us to a place where we can start thinking not only about what are we going to do next to move up the curve to make things better, but what are we going to do to improve the late effects profile or the quality of life or to avoid late toxicities as kids grow up. Yeah, this is kind of what I mentioned before my time. So that's 1971. Kids with stage 4 neuroblastoma, nobody survived. 1971. So some number of years. Who was born in 1971? You know how many years that is? 60 years ago, something like that? Is that right? No, not that many. 50 years ago? Okay. And then over time, you can see in this the figure of the survival curves that the those curves sort of indicate the year of the study. So over time, each curve shows that more and more people survive high-risk neuroblastoma in each era. So the top curve is kids treated between 2005 and 2012. And the bottom curve is kids treated between 1990 and 1994. So sort of that's, what we say there is we've pushed up the curve. So as a pediatric oncologist, all pediatric oncologists take care of ALL patients. ALL is the most common childhood cancer. Therefore, there are a lot of kids that have it. Therefore, you can do a lot of clinical trials. And over time, this is just showing, the first curve is just showing from 1975 to 2003 that survival went from 40% to 90%. So if you can do the trials and you can make things happen, you can think about exactly what I said earlier, how to change the trials. When you have a 90% cure rate, maybe you can think about what are we going to do differently. The middle picture are the woman on my left had ALL as a 4-year-old, and the woman on the right is her identical twin sister. And they looked identical until we treated one of them for ALL. And so you can see that the one who was treated for ALL a long time ago, when not everybody was cured and she needed this therapy, she got brain radiation. She had short stature from brain radiation. Her hair didn't grow back. She doesn't look like her identical twin sister. And my ALL friend colleagues have spent really since 2003 to now figuring out how are we going to change ALL therapy so the next set of identical twins, they come out the same. You have ALL, you get treated, you're done, and you're fine. And they can actually do that in ALL now for many patients. They've gotten rid of radiation. They've gotten rid of therapies that make people infertile. They've gotten rid of therapies that affect hormone development, etc. So that's our goal in neuroblastoma. I'm going to breeze through this one because I think someone showed it already. Is that right? You saw this one already? So I've been talking about late effects. So late effects are the health that you have after you're treated for childhood cancer that you wouldn't have had if you hadn't had childhood cancer. So those are not only from the drugs we give and the radiation we give, but maybe from the interaction between your lifestyle or the lifestyle of a survivor and a drug that they got, or maybe an underlying genetic factor, or maybe some people, only girls are affected and not boys. So it's important to keep in mind that a lot of this is very what we call multifactorial, which makes it even harder to study. However, as I mentioned earlier, we have been able to do a study which we call the LEARN study. Do I have any LEARN participants in the room or parents of LEARN participants? So the LEARN study stands for Late Effects After High-Risk Neuroblastoma. And it's a study that was funded by the St. Baldrick's Foundation and supported by the Children's Oncology Group, in which we were able to really look closely at high-risk kids with high-risk neuroblastoma who were 5-year survivors. In order to be in the study, you had to be diagnosed after the year 2000. And the reason for that is after about 2000 was when people stopped doing total body irradiation. And total body irradiation, so we wanted to sort of capture more modern therapy. And that we wanted to really focus on the high-risk patients because most of the data we had in neuroblastoma survivors was in low and intermediate risk patients. Here were the goals of the study shown here, and the main thing we wanted to do is really look at the prevalence or how often certain late effects occur and what the risk factors are for them. So all the different COG centers enrolled patients from around the country. Parents gave consent. They filled out a ton of forms. We abstracted the charts. And we got copies of the audiograms and the echocardiograms and the bone age and the dental studies and the pulmonary function tests and lab tests and physical exam and medications and some information about family history and information about education and quality of life measures, fracture history, second cancer history, pubertal and reproductive history. And then we looked at the therapies to try to see which therapies are associated with which outcomes. So overall, most of our patients got very high doses of a drug called cisplatin. People familiar with cisplatin? A couple of nods, yes. Some people got doxorubicin, also known as adriamycin. A lot of people got doxorubicin, but not very high doses. 80% of patients got one transplant, 20% got two transplants. These are the transplant regimens, kind of what you got in order to get your transplant, to get you through your transplant. 2/3 of the patients got immunotherapy. Almost everybody got cisRA, and a small percentage got MIBG therapy. So that gives you a very heavily treated group of patients who are 5-year survivors of high-risk neuroblastoma, at least 5 years. So I think this is the one you saw earlier today. So what did we find? We found a very high risk of ototoxicity, of hearing loss. About 60% of patients would require hearing aids based upon their audiogram. These are the endocrine toxicities. So a small percentage had growth hormone deficiency, and a larger percentage had significant short stature. There was prediabetes and diabetes in a group of patients. Many patients had hypothyroidism or thyroid nodules, and about a quarter of the girls who were old enough to look at or to measure had premature ovarian failure, meaning their ovaries, they went through menopause early. Keep doing that, sorry. We looked at organ function. So this is kidney function. Again, less than 10% had problems with their kidneys. Abnormal kidney function can cause hypertension. And then a small percentage had pulmonary hypertension, congestive heart failure, or restrictive lung disease. These are cardiopulmonary toxicities. And 4% had second malignancies. And the other important point here is that there was an overlap, meaning it's not like a person just gets one of these things. This is a Venn diagram. Remember those from school where the circle indicates who gets what. So there's a big circle, 146 kids had hearing loss, but it overlaps with kids who had growth failure and kids who had restrictive lung disease or kids who had secondary malignancies. Of note, there were 57 patients, or about a third, help me out here again, 20%, 15%, who didn't have any of these major late effects, which is really kind of interesting because we really would like to know what is it about those kids that protected them? Is it something genetic? Can we learn from them too? Let's talk about height for a minute. So if you look at this is hard because I'm used to like pointing. If you look at the dotted line, that's the normal distribution of height. So when you want to like chart out people's height, you can't do it by how tall they actually are, because in kids it depends on how old they are. And then there's men and there's women. They have different height curves, but you can normalize the curve around 0. So you see the 0 there on the bottom, and that's the highest peak in the dotted curve. So that's the distribution of normal height. So way over on the high side above 2 are like basketball players, like normal height, but very, very tall. And way over on the other side, sort of a little bit less than the -2, is normal height, but very, very short. So we looked at the height distribution in our cohort. Now that you're experts on height distribution curves or normalized curves, yes, everybody got it? Yeah. So we looked at the kids who had a single transplant as opposed to a double transplant. And what you can see is that the curve, that's the bars in blue, are sort of represent each of the groups of kids who had a single transplant. And the middle, I really wish I could point. This is the curve, this blue curve is the single transplant. These blue bars represent the kids who got single transplant. Remember I told you about 80% of kids got single transplant. So you can see the distribution of height in the ones who got single transplant. And then the red bars, remember I told you it was only 20%, so it's a little less certain. It's a little messier of a curve. But if you draw a curve for the double transplant kids, it's here. So the peak of the curve for the double transplant kids is here. And the peak of the curve for the single transplant is the top of the blue one, is about here. Now, it doesn't really matter so much if you're tall or short, as long as you're not too tall or too short. Like, in other words, there's lots of people who never got transplant who are 5 feet tall. And there's lots of people who are never, or, you know, who are 6'8" or 6'10". So that's why it's a normalized curve. So we're not too concerned about all of these kids. They're fine. They're right in the middle of the curve. The curve shifts down, but it makes us concerned about these kids, right? Because they're really short, and we want to help with that. What we don't know is if growth hormone helps for that. Some kids get growth hormone, and some kids don't. Parents who have thought about growth hormone have to deal with a question of whether growth hormone could promote tumor growth. And first and foremost, we want to cure the neuroblastoma. I mentioned that there was a 4% risk of tumors in our cohort. Those were the kind of malignant tumors, but there's also benign tumors that some of you might have dealt with. One is called fibronodule or hyperplasia, or FNH, that we find very commonly in kids who had neuroblastoma. They're just there. They don't do anything. We don't worry about it. It just scares people because they get a scan with a name. Same thing with osteochondromas, which are growths in the bone. They don't go malignant. They're just there. Some people have them taken out because they're deforming or because they hurt, but also they're benign tumors. Then the other problem that I didn't mention is dental problems. We've seen a lot of problems in kids who had neuroblastoma because maybe the young age of treatment, the radiation, and it includes missing teeth, small teeth, develop short roots, developing dental decay, discoloration. We very much recommend that anybody who's getting dental work who had neuroblastoma see a specialized dentist who has some familiarity with that. And I mentioned earlier that we get a lot of quality of life outcomes from the LEARN study. How do people do in terms of education? How do people do with the hearing loss in terms of needing special accommodations? There's a battery of results from our 376 kids who filled out a ton of forms about their quality of life, their functional status, that will be analyzed by our psychologists and should be coming out soon. So next year, I think we should invite one of them to give you more information about that. But there's so much we don't know. So we have, what's the risk of late relapse? What's the outcome after relapse disease? What are the late effects of these newer agents? We really couldn't study retinoids because everybody got them, so we couldn't tell the difference between people who got them and people who didn't. Immunotherapy, single versus tandem therapy, exposure to MIBG, therapeutic MIBG, ALK inhibitors, DFMO, proton beam radiation. These are all emerging therapies that we need to study, but we have not yet. And so we're putting together a study which we call Learn 2.0, and we'll be submitting it to the NIH and hoping that we'll be able to find out some of these things. We also only did the cohort, the Learn cohort was what we call a cross-sectional cohort. So it means we only measured things once. And we're going to try and Learn 2.0 to make it what we call a cohort that we can follow over time. And so we're going to try to find the kids who enrolled in the original cohort and then continue following them prospectively. I think the big question is, what late effects can we avoid now? And what can we do to take care of survivors so that the late effect burden is as little as possible? We in pediatric oncology, I'm a member of the Children's Oncology Group steering committee, and we spend a lot of time talking about what my colleagues in ALL talked about now a couple of decades ago. What can we get rid of? Is the late effect so impactful on quality of life and these kids' futures that we need to take out that therapy? Is it safe to take out that therapy? Now that we have chemoimmunotherapy given together, dinutuximab with chemo, and we've seen such nice responses, does that mean we can get rid of transplant or get rid of double transplant? That's a big question. Can we get rid of some of the cisplatin so that we have less hearing loss? The other things that we're doing, and then we'll get to the discussion about patient and parent preference, the other thing we're doing is doing more and more ovarian tissue preservation, testicular tissue preservation, recommending that girls or young women who have been through therapies like high-risk neuroblastoma, if they have retained ovarian function, consider freezing eggs. We're writing a trial as we speak to try a drug that has been shown to reduce hearing loss in the setting of platinum, to give that drug with high-risk neuroblastoma therapy. It's atorvastatin, which is a commonly used statin in adults, and they sort of serendipitously figured out that adult patients who were getting cisplatin, who were on atorvastatin, had less hearing loss than those who did not take atorvastatin. So we're going to study that in our patients. So patient-parent preference, we don't do that a lot in pediatric oncology. You know, if you're a person diagnosed with prostate cancer or breast cancer today and you go see an oncologist, they'll give you a couple of different choices based upon your values of how you might be treated. So a typical breast cancer patient might be offered a mastectomy and radiation. Done. Surgery, radiation, done. No chemotherapy, no hair loss. That's it. Or will be given chemotherapy to see if the breast cancer shrinks, and if it shrinks, then maybe they can do breast sparing surgery, but you're going to lose your hair and you'll miss work. So you can make a decision as a 55-year-old woman with your partner or with your children about what you value, what's going on in your life, how what you need to do at that period of time in your life. Prostate cancer is the classic with that, that men can have surgery, they can have radiation, they can have hormone therapy. The hormone therapy blocks testosterone. The surgery could leave them with urinary incontinence or sexual dysfunction. They kind of have to, they ask a lot of questions of their oncologist, and then they have to make a decision. We don't do that a lot in pediatric oncology. Your oncologist, when a child is newly diagnosed, your oncologist comes in and says, here's the best therapy we have. And sometimes parents say, or go shop around a little bit. What are they offering here? What are they offering here? Why is this different? What should I get? It's usually focused, though, on who's got better cure rates. What's the outcome in terms of curing neuroblastoma? But we're getting to the point, we're getting pretty close, where we might be asking parents, you know what, we always gave 2 cycles of cisplatin and carboplatin in our transplant, and we know that leaves kids with a 60% chance of needing hearing aids. We're studying this. We're cutting out one of the platinums. We're reducing the platinum by 50% during induction because we hope that will give less hearing loss, but we don't know what that does for neuroblastoma. So the doctors feel comfortable enough doing this. Let's just say there's a hypothetical, not an actual trial. But we haven't ever really kind of learned how to take parent/patient preference into this sort of algorithm. We make decisions about what to get rid of based upon what we imagine, but not what we know about being a parent of a kid with neuroblastoma. And I remember my patient's parents saying, I don't care what you do, take her, do what you need to do, cure her, and get her back to me. Like, it can't be any worse than losing her, And I'm a parent, I get that. But I do think we're at a point now in high-risk neuroblastoma where we will be talking about what we should and shouldn't be doing based upon parent preference, or having a really well-educated parent who sits down and understands the risks and benefits of each of the components of the therapy and then makes a decision informed by the doctor. I think that's where we're going, and I think we're going there not only for cure of high-risk neuroblastoma, but because we have long-term survivors in whom we have to worry about their quality of life. How am I doing with time? I don't see a couple more minutes. Only a couple. Then I'll stop there and take questions. How about that?
All right, sounds good. Thank you, Dr. Diller.
Sure. I have a lot more.
Did you want to post it?
There you go.
You want to go through anything?
No,
Okay.
If there are questions,
All right. Does anyone have any questions of Dr. Diller? Go ahead.
Vicki
sorry,
Binger.
Vicki.
Sorry.
Go ahead.
Vicki Binger. I am very curious about your conversation about hearing loss and statins. The community was under the impression that the PEDMARK product was actually pretty good, and that the problem was that it was not being used in hospitals rather than because it didn't work. Are we not? Do we not have a product that helps with the platinum drugs and hearing loss already?
Yeah, so there is a product that reduces platinum-induced hearing loss by about 50%. It's given IV and has been tried in a number. The FDA approval is around only localized disease. The reason is that the patients who had metastatic disease had a higher risk of relapse. So it is not approved. You can correct me if I'm wrong, but my understanding is it's not approved for localized disease. for metastatic disease in high-risk neuroblastoma, for example. The other thing that's happening with that is thinking about formulations that are given locally of that product, and the problem there is the age of the kids. You know, that in order to get the product into the middle ear so that it gets into the cochlea and protects against platinum, the child has to be under anesthesia, and it has to be done within a few hours of the systemic platinum administration. So it's a little bit of a logistic nightmare, and ends up having to give a child more anesthesia than they otherwise would have gotten. So we talked a lot about bringing that up as a high-risk neuroblastoma protocol, but now this statin one is pretty exciting. So, yeah.
Over here.
Hi. It's been really great today just to see that there's more consideration of changing some of the protocols, still having effective treatment of neuroblastoma, but then minimizing the late effects. And it seems clear that if there's a way to successfully treat neuroblastoma without having tandem transplant, then that would solve a lot of the late effect issues. So it's exciting that there are some studies, COG studies, because I know it's been done and other centers, some COG studies on that. I also wanted to ask, in terms of late effects, whether or not there's any thought of helping families navigate health during treatment. So when you have an adult that's treated for cancer, there'll be lots of talk about, what they can do to stay healthy overall. Now that we know that a lot of the success of neuroblastoma treatment is through immunotherapy, are there any thoughts on helping parents, especially parents that maybe don't have built-in resources to navigate things like, more general healthy living that could help their kids deal with treatment better, and then maybe, even help them get to a point of having better survivorship?
Sure, those are great questions. There's a couple of studies going on. One, Dr. Kira Bona is doing with colleagues to really look at the about 20 to 25% of kids who have what they call household material hardship, or poverty, so that it affects their ability to have a healthy diet, to have a clean and heated home, to get back and forth to doctor's appointments, and using an intervention in that group. So that's in a sort of an at-risk group, and trying to ameliorate some of the economic toxicity, or the economic challenges of a kid going through, or a family going through, high-risk neuroblastoma therapy. Another of my colleagues, whose name is Katie Greenzang, her area of expertise and the focus of her research is bringing survivorship conversations up earlier while a family is getting treatment, which is not exactly what you said, but it's a little bit around supporting families, so that it's the paradigm that kind of I've lived through in my lifetime is like, you have this consent conversation, you mention some of the late effects, you get the parent through the upfront stuff, you're dealing with fever, neutropenia, and lines, and surgery, and recovery from chemo, and all that. And then when it's all over, there's this sort of like period of time that's just like fear of recurrence, and then suddenly you're like, oh, and now we have to talk about all this other stuff. And I think that's an antiquated paradigm. I think shifting the paradigm so that we're talking about all these things all the way along is kind of the right way to do it. So we in oncology talk about that conversation when we tell you about the diagnosis and how we propose to treat it as kind of day one. And her paradigm is day 101. That on day 101, we start talking about what it's going to be like, what's happening, how to get you through this, how to live the best possible life during, and be ready for after. So yes, I completely agree. Yeah. Other questions?
Anyone else? Nothing? Okay.
Thank you so
Doc.
much.
Thank you, Dr. Diller.